Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we take a look at recent medical news and headlines. We know medical news can be difficult to understand, and it's hard to know which sources you can trust. This podcast format gives us time to dive deep into the science as well as into the controversies. Our goal is to review the latest medical news and trends in a non-biased way and to present it in a format that is understandable. If you are new to this podcast, we're so happy you tuned in. Welcome. I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. So as you guessed from my job title, I talk to people all day long about their pain. Pain is the primary reason people go to any doctor, not just to a pain doctor. Pain or discomfort is our body's way of protecting itself from harm. But it's more complex than that. It's a complex interaction of signals from the body to the brain, and from the brain back down to the body. And pain elicits emotions that interact with the painful stimuli themselves, oftentimes worsening the pain. Pain isn't simple. That's why I have a job, right? So when I saw the headline, yes, the pain is all in your head, I thought, oh my, now that's a good way to get people upset. As a doctor, I know where and how pain's processed, so I know it's actually in the brain. But generally speaking, when patients hear that it's all in your head, they think someone is accusing them of making it up or exaggerating or misrepresenting. So let's dig into that little headline a little deeper and figure out the meaning. So have you ever gone to the doctor and been asked to rate your pain? Just about everyone has. I have. Typically, you're asked to rate your pain either from 1 to 10 or 1 to 100, with the higher number being an unimaginable degree of pain. Think being mauled by a bear level of pain. Or maybe you've been presented with that strip of faces. The one end is a smiley face and the other end is the crying face, and you're supposed to say where your pain is on that spectrum. These various scales, the numeric scales or the FACES scales, are all very subjective and very inconsistent. Every doctor will tell you of patients with a horrible injury who say their pain's 2 out of 10, and then another person with a minor boo-boo telling you their pain is 10 out of 10. What does any of that actually tell the clinician? I can attest these scales are kind of useless to clinical practice. We get the numbers because we're required to document them for insurance purposes, but they honestly don't help me decide if a patient's improving or not. For instance, I have many patients who always circle 10 out of 10 for their pain severity. So if I just looked at that on paper, I would think these people are constantly being stung by 1,000 bees and no treatment has ever helped them. But then I go into the room and they say, "Hi, doctor, my injection or my medicine or my therapy is helping and I'm significantly improved." Obviously, there's a disconnect from these numbers to what I am clinically seeing in that patient. Pain is not just a physical state of being. It's a subjective and emotional response. That is the very definition of pain that we all learn in medical school. This makes pain very difficult to measure or quantify in any meaningful way. That's why doctors usually look for functional improvements instead of pain reduction as a marker of clinical improvement. Pain is intimately linked to emotion and vice versa, which further complicates things. There's the pain itself, and then there's the suffering associated with it. And we all know people who are more sensitive to or seem to have more emotional distress from their pain than others. So having an accurate measurement of pain is difficult due to limitations in how we actually measure it and the emotional impact of pain being highly variable. Wouldn't it be nice to have some biological measurement of pain to help the patient and the doctor both be able to see an objective marker? I mean, wouldn't it be great if the patients and the doctors could basically be speaking the same language when it comes to degree of pain? Well, in January, the main outcomes of the PREDICT trial were published in JAMA Neurology. This study used non-invasive brain studies, EEG, and TMS, or transcranial magnetic stimulation, to try to objectively measure the level of pain a person's reporting. To do this, the authors injected nerve growth factor into the muscle of the jaw in 150 healthy people without chronic pain, who I hope were reimbursed nicely. Nerve growth factor is painful when injected into muscle and remains painful for some time afterwards. The authors used a statistical analysis to break down participants into two groups, those who had initial severe pain and those who had milder reports of pain. The authors then looked for a biomarker to help show which group patients fell into. They studied specifically the EEG and TMS as biomarkers. On EEG, a measurement called the sensory motor peak alpha frequency, which is a measurement of the rate of oscillation of brainwaves, was recorded, and a slower peak alpha frequency was predictive of increased reported pain. On TMS, the examiners looked at something called corticomotor excitability, which is the efficacy at which the signals are relayed from the primary motor cortex in the brain to the peripheral muscles. They found that a slower signal was associated with more pain. So, using these two measures, they found that the slower peak alpha frequency and the slower corticomotor excitability were associated with higher reported pain with 88% accuracy. Wow, right? Given the higher acute pain predicts the development of chronic pain, these results suggest that these measurements potentially could be used as susceptibility biomarkers for the transition from acute to chronic pain. Now, guys, that could be a game changer. If a person could be identified early as susceptible to developing chronic pain, wow. I mean, could we intervene differently in this population when they're having a surgery, like a major back surgery, to help them recover better? I mean, that's great, right? So earlier I talked about the emotional experience of pain, and the authors looked at something called the pain catastrophizing scale, which helps quantify some of that emotional response to pain. How does a person think about their pain? Do they ruminate on it more than average? Do they have more anxiety about the idea of pain? Adding in the psychological measurement did not improve on the objective measures in determining who has higher reported pain. Now, some have suggested that this shows that it's not that some people have a worse reaction to the same level of pain, but that different people's brain process pain signals differently. On the converse, though, it may just be the scale they used. The pain catastrophizing index and potentially other scales could have been more beneficial. Since the brainwave changes did not explain more or less reported pain in about 10% of the time, we're still looking for other factors that would then have impacted pain sensitivity. And of course, this study didn't tell us anything about other factors that might have resulted in brain processing pain differently. For instance, we know that adverse childhood events or traumas are a significant risk factor for a diffuse pain condition called fibromyalgia. All right, now that is a whole other big hot topic, and we might want to get into that in another podcast. But for now, we're just going to say that trauma is a big risk factor for developing some chronic pain conditions. Knowing exactly the brain processing changes in people with the history of trauma would be interesting in the future, and maybe we'd be able to reset that aberrant processing to a more normal state. Okay, now not to sound conspiratorial or anything, but I do not relish the idea of a day where there's a brain scan done and then a patient is doled out pain pills commensurate with the speed of their brain spikes. I am less interested in this technology as a way to say who does or doesn't have pain. I am much more interested in it as a way to predict people who are at risk for developing chronic pain and then maybe develop better intervention strategies to keep them off of that chronic pain train. Thank you so much for joining us. I really hope this episode gave you some insight and cleared up some misconceptions. If you haven't already done so, please go ahead and subscribe. We don't want you to miss out on any of our upcoming podcasts. Thank you again. Wishing you good health, and see you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.